Bismillah ar-Rahman ar-Rahim. Welcome again fourth-year EMP students. This is the second part of my presentation titled Basic Clinical Management of Preterm Labor and Preterm Birth. In the first part, management of asymptomatic at-risk women for preterm labor was discussed. In the second part, we will discuss symptomatic women with threatened and established preterm labor management. As for women with threatened preterm labor, management will follow as evaluation, information and explanation, then counseling for the condition followed by supportive care and intervention that may prevent the occurrence of the condition. Initial evaluation is to assess the benefits versus risk of maintaining pregnancy. First group of questions, we should confirm the diagnosis. Is it preterm? Is it true labor? You should exclude false labor by documenting cervical change. And if true labor, whether it is early versus late established labor. Also to evaluate if labor is imminent. That's to say the risk of delivery within 7 to 10 days is suspected by either a short cervix or a positive cervicovaginal fibronectin. Diagnosed or impending preterm labor is defined as occurrence of uterine contraction more than 4 per 20 minutes or 8 within 60 minutes with either cervical dilatation more than 3 centimeters or a transvaginal sonography with a cervical length less than 20 millimeter or the transvaginal cervical length between 20 to 30 millimeter with a positive fetal fibronectin in the cervicovaginal fluid. It should be separated from those with possible threatened preterm labor as line of management may be different. The second groups of questions, if there is identifiable treatable condition which should be treated as UTI or lower genital tract infection. The third group of question, if there is clinical significant or non-reassuring unstable maternal or fetal condition or a pathology which need a termination of pregnancy and contraindicate maintaining pregnancy. Lastly, the fourth group of questions is to determine the place of care and the possible need of intrauterine transfer to a tertiary hospital with better NICU facilities. These questions are answered through the following: the classic history, examination, and investigation procedures in clinical medicine. During the face-to-face session, we will discuss how to evaluate a case of threatened preterm labor and how we will formulate an algorithm for management. Possible interventions for threatened, diagnosed, or impending preterm labor are tocolysis and the 3 measures to improve neonatal outcome and a possible intrauterine transfer. Tocolysis are medications used to stop uterine contraction and is only offered as short-term protocols to delay delivery to allow maximum benefit from the antenatal steroids, corticosteroids, to enhance lung maturity. Other indications may be to allow safe transport of the mother to a facility with optimum NICU care. Furthermore, it may be used to guard women against preterm labor while undergoing surgical procedure threatening her pregnancy. Contraindications are mainly related to the selected therapy used. 6 groups of tocolytic drugs are listed. Choice of the drug is related to the gestational age, as seen in the following table. The student is advised to use reference text for detailed drug dose and complication. 3 main interventions are used to improve neonatal outcome. Antenatal corticosteroid therapy reduced the incidence of the RDS, intraventricular hemorrhage, necrotizing enterocolitis, and neonatal mortality by almost 50%. Maximum benefit after 24 hours from the last steroid dose. It is given for threatened preterm labor between 24 and 34 weeks of gestation. Repeated courses is not advisable, although a rescue course may be given if more than 2 weeks elapsed since the last steroid course, or if the first course was given below 28 weeks. Antenatal magnesium sulfate administration decreases the risk of cerebral palsy and severe motor dysfunction in the offspring. It is limited to gestational age below or equal to 32 weeks, even if emergency delivery is anticipated within 4 hours. Group B streptococcal prophylaxis are given to all preterm labor with a positive GPS culture or an unknown culture state. Therapeutic GPS therapy must be given if intrapartum fever develop. GPS prophylaxis may be omitted if elective preterm cesarean section is indicated with intact membranes. Antimicrobial therapy are not used as a tocolytic, yet it is used therapeutically if indicated, as evidenced by chorioamnionitis for 7 days, whether membranes are intact or ruptured. Doses and drugs are given when, with the pre-labor rupture of membrane lecture. Further discussion for antenatal steroid, magnesium sulfate, and GPS prophylaxis will be done during the face-to-face session. After inhibition of threatened preterm labor with a stable patient and a reassuring fetal state, outpatient treatment management is suggested. Bed rest is not recommended. Sexual activity is avoided. No prophylactic antibiotic. No maintained tocolysis. Fetal fibronectin testing and home uterine activity monitoring are not useful. Continue progesterone supplementation only if it has been given before. Transvaginal sonographic measurements of cervical length may be done after 2 weeks. As regard birth time, 34 weeks to 35 weeks of gestation is the threshold at which perinatal morbidity and mortality are too low to justify the potential maternal and fetal complication and cost associated with inhibition of preterm labor, which will only result in short-term delay in delivery. Thus, if diagnosed preterm labor more than 34 weeks in a stable parturient lady with intact membrane, she may be admitted and labor stimulation started. Yet, if there is uncertainty of gestational age, documentation of lung maturity is mandatory. And if any suspicious of lung maturity, you should manage as 32 to 34 weeks. Of course, all unstable preterm labor with significant maternal or fetal pathology should be managed accordingly, example with pre-labor rupture of membranes or with hypertensive disorders. As regard birth management, you should avoid prophylactic or elective episiotomy, low forceps, and cesarean delivery for preterm birth babies without other obstetric indications. Vacuum-assisted vaginal delivery is contraindicated below 34 weeks. Delay cord clamping is advised. Maternal analgesia is guided by maternal need. Lower segment cesarean section is done, no need for upper segment cesarean section, yet avoid small skin incision. Preterm labor with multiple pregnancies and with pre-labor rupture of membranes will be discussed with related topics. An algorithm for management of preterm labor will be revised with the students during face-to-face session. For this clinical case, the student is advised to prepare for discussion in the face-to-face session. A 38 years old female, para 0211, with one mid-trimesteric abortion and 2 preterm deliveries at 30 and 24 weeks, with one living female, 5 years old, after a spontaneous vaginal delivery with NICU admission for 14 days. Her last delivery is 3 years. Her last abortion is 1 year. She is pregnant 10 weeks and seen at the outpatient clinic with mild abdominal pain. Her vital signs were normal. Abdominal examination was unremarkable apart from the uterus is felt at the symphysis pubis. Question 1. What further questions you need to ask to complete your evaluation? Question 2. What further signs and investigations you need to perform to complete your evaluation and reach a final diagnosis? Question 3. What is your final diagnosis? Question 4. What's your plan of management, further evaluation and intervention? Lastly, is there any alternative management and what is its rationale? Hope the presentation was clear and helpful. The student is advised to read the recommended text and see YouTube's links and be prepared with questions and discussion in the next face-to-face session. Thank you for your time.